Hello everyone, welcome to my channel. Today we are starting one of the most important and practical topics in medicine, which is critical care medicine. So I have made a lot of notes and highlights in this chapter to explain you guys in a very structured and simplified and exam friendly way. So in this video I'm going to take you through the approach to critically ill patient step by step based on Harrison's principle of internal medicine 22nd edition. So what exactly is critical care? It's about managing the patient who are at the edge of their life. These patients are at the extremes of their physiological deterioration. In other words, if you don't act immediately, they will collapse. So it's unlike the ward medicine where we have time to take history, do investigations, and then decide to plan for their management. But in critical care, the very first priority is resuscitation and stabilization. So basically, we have to save the patient first and then worry about the underlying disease. I have highlighted a line in Harrison saying that the resuscitation is often fast paced and occurs early when detailed awareness of the patient's chronic medical problems may not yet be possible. So, before knowing their history, we will resuscitate them, and then later we worry about their underlying disease. So, we will be covering about the overall approach to the critically ill patient and how to assess illness and severity using the ICU scoring systems, then the basics of shock evaluation. Then I'll be also talking about the mechanical ventilation. So when a critically ill patient arrives in the ICU, the first steps in is always resuscitation, where we follow the classical ABCD approach. So A for airway, B for breathing, C for circulation, D for um, disability, and E for exposure. So the very first question when the patient arrives is the airway patent or not? If the patient cannot maintain airway reflexes or if there is any obstruction, we have to do an immediate intubation if needed. So then we have to assess the breathing, look for respiratory rate, chest movement, oxygen saturation, and if possible check an ABG analysis, which is arterial blood gas analysis. So and like hypoxemia or hypercapnia can be a life threatening if not corrected at early stages. So then we have to check for a circulation, pulse, blood pressure, capillary refill time, urinary output, and other circulation related things. If circulation is failing, fluids and vasopressors may be needed. Then this one line sums up the ICU work, which says that, which I have already said before. Then why ICU is unique? Because in ward we won't do these mechanical ventilation or renal replacement therapy or invasive hemodynamic monitoring. That's why ICU is a very special place for this kind of patient. So we do mechanical ventilation, dialysis like renal replacement therapy, and invasive hemodynamic monitoring. The exact goal is to use this window of opportunity. So the exact philosophy of critical care is treat aggressive, stabilize physiology, and target the root cause. Okay, so next we'll be seeing about the assessment of illness severity. Now every patient in ICU is not the same. Some may be critically ill but have a good chance of recovery, while others may not have the same prognosis. The prognosis may be poor. So how do we assess the severity? The ICU scoring system comes here with where there are a lot of scoring systems in ICU, but Harrison emphasizes only these two systems like SOFA score and APACHE score. So the SOFA means the sequential organ failure assessment, and the APACHE means acute physiology and chronic health evaluation. The reason interest is also on qSOFA, which is which doesn't need for lab evaluation. It's a bedside quick screening tool. It's called qSOFA. So the SOFA scoring system is composed of scores of 6 organ systems, grading from 0 to 4. So Harrison has given the table where we see the 6 organ systems like respiration, coagulation, liver, and cardiovascular, central nervous system, and the renal system. So the respiration is based on partial pressure of oxygen divided by fraction of inspired oxygenation. And coagulation is based on the platelet count. Liver system is based on the bilirubin levels, and the cardiovascular is based upon the mean arterial pressure and vasopressor requirement. Then CNS system is based upon the Glasgow Coma scale, and the renal system is based upon the creatinine and urine output. You can even take a screenshot of this scoring system, which may be useful for your exams or other things. And so this SOFA score is used to describe the organ dysfunction or the organ failure. So the higher the score means the worse the prognosis. For example, if a patient with SOFA score of 12 has a much higher mortality risk compared to the one with a score of 4. Also, the recent sepsis guideline says that increase of at least 2 points in SOFA score from baseline is diagnosis of sepsis. So, um, so if a score increases by 2 or more points, that itself defines sepsis. Also, increasing SOFA over the first 48 hours in ICU strongly predicts poor outcome. So now the problem with the SOFA is we need the lab to know about these values, but in qSOFA we don't need the lab values. We just need a bedside examination like respiratory rate, altered mental status, and systolic blood pressure. Respiratory rate more than 22 breaths per minute, and altered mental status is based upon the Glasgow Coma scale, and systolic blood pressure less than or equal to 100 mmHg. So yeah, so but qSOFA is a quick screening protocol in ICUs. Next, we'll be seeing about the APACHE II scoring system. This is most commonly used in North America. So it has rectal temperature, a mean blood pressure, heart rate, respiratory rate, arterial pH, oxygenation, serum sodium, serum potassium, serum creatinine, hematocrit, and WBC count. And if you want, you can take a screenshot of this whole scoring system. Also, you can see the Glasgow Coma Scale, where eye-opening, verbal, and motor activity is there. Verbal can be also based upon the non-intubated patient and intubated patients. So the scoring system is must known for the students or the exam going students. So Harrison mainly emphasizes on qSOFA and APACHE II scoring system and qSOFA. So Harrison has given one more graph about APACHE II scoring system, where the y-axis tells about the mortality rate and the x-axis tells about the APACHE II score, where you can see the score about 25 to 29 or 35 plus has higher mortality rate percentage. So Apache scoring system is mainly used for prognosis, benchmarking ICU outcomes, and it's still in research trials, not for moment-to-moment bedside decisions. So yeah. So next, so the most common emergencies we face in ICU is shock. So how do we define shock? Shock is basically defined as the presence of multi-system end-organ hypoperfusion, or basically we can tell it as inadequate tissue perfusion leading to organ dysfunction. So the clinical features include hypotension, tachycardia, cold skin or warm skin in septic shock, altered mental status, reduced urine output. These are the clinical features we see in shock. Then there are types of shock like hypovolemic shock due to blood loss or fluid loss, cardiogenic shock from myocardial infarction or pump failure, distributive shock like mainly sepsis or also anaphylaxis, obstructive shock like cardiac tamponade or tension pneumothorax. So in Harrison, there is a flow chart like about the shock. There is cold shock and warm shock, where cold shock has low cardiac output, high in warm shock there will be high cardiac output. The warm shock is usually with septic shock, where we have to give aggressive antibiotics resuscitation, and whereas in cold cold shock, we see cold cardiac output, where we can again divide them into high JVP and low JVP. High JVP is where the heart is full. We can tell that it's cardiogenic shock, and low JVP where the heart is empty, uh, which is hypovolemic shock. In high JVP, we evaluate for myocardial ischemia. Then we have to consider for echocardiogram and vascular monitoring. Then later we have to administer inotropes. Then we have to reduce the afterload. Then in hypovolemic shock, we have to give IV fluids. Then if there is still no improvement, then we have to consider for thinking about adrenal crisis, right heart syndrome, pericardial diseases. Then we have to consider echocardiogram, then invasive vascular monitoring. Then aggressive IV fluid resuscitation may also convert to high cardiac output, then may lead to septic shock, and again we have to resuscitate aggressively. So in hypotensive patients with signs of reduced cardiac output, an assessment of intravascular volume status is appropriate. So yeah, in volume less people, like blood loss or vomiting or diarrhea or polyuria, uh, the intravascular volume status is appropriate. So we have to also see about the JVP, which measures about the right arterial pressure, but this does not predict the fluid responses reliably. So the change in right arterial pressure as a function of spontaneous respiration is better predictor of fluid responsiveness. So you can see a figure here in Harrison telling that right arterial pressure changes during spontaneous respiration in a patient with shock, whose cardiac output will increase in response to IV fluids administration. And then the right arterial pressure decreases from 7 to 4. The horizontal bar marks the time of spontaneous inspiration. So then other bedside metrics can help with judging whether the patient remains fluid responsive or not, like uh, straight leg raise test that correlates with improved perfusion, and other bedside metrics can be done. Then in hypotensive patient with increased intravascular volume and cardiac dysfunction may have S3 and S4 gallops on examination, then increased JVP, then extremity edema or crackles on lung auscultation. Then classically we can see curly B lines on chest X-ray and pulmonary edema. All these things can be seen during shock. These findings can be seen during shock. Then so it's all about the shock which I have explained in this flowchart. So ideally after uh, knowing the patient is deteriorating, we have to uh, uh, insert lines under a sterile condition using protocolized checklist approach, and the line should be removed as soon as they are no longer necessary to avoid risk of line associated infection. So yeah, then this flowchart brilliantly explains about the clinical features like cold extremities versus warm extremities, and can help us classify shock at the bedside. So basically the initial management of shock is airway and oxygenation, IV access and fluid resuscitation. If no improvement, add vasopressors, and then first line of vasopressors is norepinephrine. So then if we suspect a septic shock, then we have to give broad spectrum antibiotics. This rapid structured approach can make the difference between survival and death. So yeah, so we will also talk detail about mechanical ventilation in upcoming videos, but what here it tells about the patient may require intubation if airway is compromised, hypoxemia persists despite oxygenation, hypercapnia with acidosis. The patient shows signs of impending fatigue. So these kind of reasons are required for the intubation. So once intubated, we connect them to ventilator. Like in ARDS, we use low tidal volume ventilation around 6 ml per kg of ideal body weight, plus adequate TEP to maintain oxygenation. There are a lot of complications like barotrauma, ventilator associated pneumonia, volute trauma, and other stuff. We'll cover this mechanical ventilation and respiratory failure in detail in next upcoming videos. So yeah, so the to recap everything what we learned in this video is the first step in managing a critically ill patient is resuscitation using ABC. ICU is a special place because it allows advanced interventions like ventilation, dialysis, and invasive monitoring. To assess severity, we use SOFA, qSOFA, and APACHE II scores. Shock is a common ICU presentation. Recognize it early, classify it, and treat with fluids, vasopressors, and antibiotics as needed. Then, mechanical ventilation is often life-saving in respiratory failure. So, in next video, we'll continue with the respiratory failure. Then we'll focus on ARDS and mechanical ventilation strategies. If you found this session helpful, do subscribe to this channel and follow the entire Harrison Critical Care series. Thanks for watching and see you in next video.